Good afternoon, everyone. I'm Brenda, and I have been a member of the GBS-CIDP Foundation International for about 6 years. I was diagnosed with MMN in 2013. I am so pleased to be moderating the Ask the Expert session today with questions directly from the patients and caregivers from the community on the topic of MMN. Joining us today is Dr. Tom Harbo. We'd like to say hello. He's our resident expert. Tom?
Hi, Brenda. Thank you for your introduction.
Well, thank you so much for being here. We really appreciate it. Okay, so let's get started. So I thought for those maybe newly diagnosed or just starting the process, it might be good if we just kind of went over a brief description of what is MMN.
Well, yeah, that's a good beginning. So you can say MMN, that's an aberration of multifocal motor neuropathy. It's a very, very rare disorder. It only affects maybe 5 to 6 out of a million population. The mean onset of age for the patient is around 40 years of age, and there is a male over female predominance in this patient category. So, as the name implies, it is a multifocal disorder, and it only affects the motor nerves. So that means that the cardinal symptoms of MMN is weakness, and it's asymmetrically. It often starts distally, often in the hands, and then it can progress from there.
So a lot of us are misdiagnosed or have a hard time getting diagnosed. And myself included, I was misdiagnosed with ALS initially. So what's the difference between ALS and MMN?
Well, first of all, MMN and ALS is very, very different disorders, but they have similarities as well. So, for instance, muscle wasting, hands especially, can be dominant in both disorders. And you can see cramps and fasciculations in both disorders. But when you see the patient, you hear the natural history and the development of the symptoms, MMN and ALS is very different. MMN is mainly a stepwise and very randomly progressing disorder. That means that it can affect muscle groups corresponding to one single nerve in the hands, and then be there for years. And then you don't know when and where it will affect the next nerve. Compared to that, ALS is a steadily progressive disorder. It can start in one hand as well, but then it tends to progress from there and spread all over the body. Also, ALS has more signs of respiratory failure, bulbar signs, and proximal weakness. And when you have had ALS for some time, then it's probably obvious in most of the cases. So I think the problem is in the beginning of an ALS, it can mimic MMN.
So during the very long process of getting diagnosed with MMN, what can we expect as far as tests that get run, just the whole process in general?
To make the diagnosis of MMN? Yeah. Well, it's very important to hear the patient's history, talk with the patient and understand how the symptoms develop. And then the physical examination where you see the weakness, the asymmetrical pattern. And if you have these, or you get this suspicion, then the most important examination, the paraclinical examination, is the EMG and nerve conduction study. And I think that's a study that will be done in many neuromuscular patients. So you put some needles in the muscle to see the electrical activity. You put a electrical current into the nerves and see how the nerves react. So that's the most important study. You can also have some blood samples. For instance, you can measure some antibodies against gangliosides in the bloodstream. And you can also do a lumbar puncture. It's not like you can confirm the diagnosis of MMN with any of these things, but you can exclude other disorders like, for instance, Lyme disorder or Lyme disease. In some centers, you can also have ultrasounds of your nerves, and you can have MRI of your nerves. So that's some of the examinations that you can see in many places. And one final thing, if you are in doubt, then you can try to treat like MMN. So if you give the patient a course of immunoglobulin and the response, then it's also a kind of a diagnostic test.
So I'm going to jump down a couple of questions because this kind of came up. So during the diagnosis part, you hear a lot about GM1 antibodies and conduction block, but not everybody has that. So can you explain why some people have them and some people don't, but they both have MMN?
Yeah, that's correct. If we start with the nerve conduction study, so to begin with, MMN was called MMN with conduction block, so you needed to have conduction block to have MMN. But we know that maybe 20% of the patient, we can't find the conduction block. So there can be several explanations for that. One thing is that you need to do a very, very extensive nerve conduction study, and you have to be sure that the nerves that are affected are examined very proximal. So if you only have done some minor conduction study with the distal nerves and you don't find the conduction block, you have to look further for that. Another explanation could be that you have secondary axonal degeneration in the affected nerves, and then you probably can't find the conduction block anymore because you lose the amplitude. That's the measurement of the response, both proximal and distally, and then you can't find the conduction block anymore. So maybe there has been a conduction block, but it has been erased because of the axonal degeneration. And I think a third cause could be that you can have MMN without a conduction block. So that's a possibility too. So if you have the right clinical signs and symptoms, then you can still have MMN. But then you have to rely really much on your clinical examination and the patient history. And to continue with the GM1 ganglioside antibodies, that's an antibody that you have in the blood. You can measure it in the blood. It's an antibody against the myelin sheath of your nerves. I'm not sure that you can say that the antibodies causes MMN. It could also be just that you have a nerve damage, and after that you make some antibodies that you can measure. The problem in the diagnostic workup is that the GM1 antibodies are neither sensitive or specific for MMN. And that means you can have MMN without the antibodies, but you can also have the antibodies and have ALS or any other neuromuscular disorder.
Okay. So I'm involved in a lot of MMN forums, and I'm always completely amazed how different symptoms are from one person to another. Just the gravity of, some person, needs walkers and wheelchairs, and like myself, I don't need any assistance getting around. Why is it so different?
Yeah, it is different because it is a multifocal disorder. That's in the name of the disease. And that means that you can have symptoms from any muscle nerve in your body. So we know that most patients have affection of their hand muscles to begin with, but you can also have neuropathy in your feet, you can have it in your shoulder, you can even have it to your respiratory muscles. So that gives really different kind of symptoms for the patient.
Okay, so I know this is probably you answered this and explaining all this, but I'll ask anyways. Why is MMN so hard to diagnose?
Well, first of all, it's a rare disorder. So that's one thing. So it's not the first disease that your doctor think of when you present with a weak hand or cramps in your feet or things like that. So it is a rare disorder. And the other thing is probably the quality of nerve conduction studies. So if you don't do a really good nerve conduction study, you can miss the conduction blocks, and then you don't think about MMN.
So I know a lot of people, because there is a lot of misdiagnosis, how can they even be sure they have it? I mean, is there any, what do you do if one doctor says no, and then, you just keep getting, I feel bad for a lot of people out there that are just struggling to get a diagnosis, and that because MMN is so rare, and, if they start treatment on that, but it's not that, it's something else. How can we even be sure that's what we have?
That's a hard question.
Sorry.
I think most of the patients present with the typical signs of MMN and have conduction block. And then you're pretty sure that you have the diagnosis. And if you even respond to immunoglobulin, then you have the diagnosis. But you mean if you're a patient that doesn't respond to immunoglobulin very well, then you maybe should reconsider. And if the disease starts to look different, to begin with, it can be difficult to see if you have ALS or MMN, but when time goes, if you have ALS, you will find out.
Okay. So we get a lot of back and forth on this in the forum, so I wanted to ask the expert here this question. So MMN is commonly not accompanied with sensory issues, but can pins and needles sensation, pain from nerve compression, or any other pain be linked to MMN?
Per definition, you don't have sensory signs or symptoms with MMN. So mostly I would think if you have these symptoms and you have MMN, then it's because you have two different disorders. So, polyneuropathy is a very common disorder that you can have even if you have MMN. Lumbar spine disorder can give sensory symptoms. Entrapments can give sensory symptoms. So if you really have important sensory symptoms, then I would consider it was due to another cause. And then you can have some very rare subtype of CIDP that mimics MMN very much because it's multifocal as well, but it affects sensory nerves also. It's called the Lewis-Sumner syndrome, and that could be an explanation. And it's really pretty similar disorders, and both can be treated with IBIG.
Okay, well, that's good to know. Okay, so can bad circulation be a symptom of MMN?
No, you shouldn't have bad circulation because of MMN, but symptoms can be similar. So if you have cramps and muscle pains in your leg muscles, it could be due to bad circulation or MMN. So you really couldn't know if it's one or the other. And if you really have weak muscles in your legs, then you can also have restricted venous back return from the legs, and you can swallow up. But bad circulation is not a symptom of MMN. So it's two different things, but in some instances it can mimic.
Okay, well, I know all about the cramping. I get that all the time. Okay, so I know for myself, I'm constantly wondering why MMN came into my life, trying to pinpoint a time and place when I was first noticed symptoms. And every time I think about it, I think I go back farther and farther. So a lot of us wonder, can MMN be triggered by a trauma like surgery or an illness?
Well, I have to say that with the current evidence that we have available, that will be a very, very speculative answer to that question. But of course, it's an immune disorder. So anything that can trick your immune system, you can speculate can induce MMN. But I don't have any scientific data that can confirm it at the moment.
Okay. Has MMN ever been linked to sarcoidosis?
No, not that I know. But again, sarcoidosis is also called the great mimics. So you can have sarcoid in your nerves that will give you the same symptoms as if you have MMN. So in very, very rare instances, sarcoidosis can be mistaken for MMN.
Interesting, okay. Okay, so on to IBIG and SubQ. So that's what most of us are on. Can you explain what it does in our bodies to help us?
Yeah, how much time do we have?
We have time.
Well, first of all, I don't think there is one explanation why IBIG or SubQ immunoglobulins help with the symptoms. So there are many theories. We know that if you give immunoglobulin infusion, then you speed up the downgrading of the immunoglobulins that you produce yourself. And if you have autoantibodies that causes the disease, for instance, the GM1 antibodies, then you will also speed up the clearance of these antibodies. So that could be one explanation why immunoglobulins help you. But I think there are several other explanations too. When you give a loading dose of immunoglobulins, then all your immune cells will link to these antibodies. And in that way, you kind of modulate your immune systems in so many ways that we actually don't know which way is the most important. So it's, yeah, you can say it's modulating your immune system.
Okay.
In many ways.
Okay. So when you start IBIG infusions, I get really frustrated because not all doctors really explain like what to expect. And so can you tell us what are normal side effects that you get with IBIG infusions, how long they last, and what's the best way to prepare for like your loading dose and the follow-up treatments after?
So now you are talking intravenous treatment?
For IBIG especially. Like
yeah, IBIG.
Yeah.
Yeah, okay. So there are some common side effects to immunoglobulins intravenously. It is infusion related. So you get the symptoms or the side effects right after you start the infusion or the next day, or even if you get infusion for instance, 5 days, which is pretty normal, then they will add on. So you get more and more side effects for each day you get the treatment. And the expected side effects are headaches, small fevers and chills. you can feel like you have the flu. And most of the time, the adverse effects will go away a few days after you stop the infusion. So that's the normal side effects to IVIG. So often you can reduce the side effects by taking Tylenol at the same time. You can increase or decrease the rate of infusion. So we know that the faster you get the infusion, the more side effects you have. So I think that's the most important things that you can do. I know in many places they give saline infusions before or after IVIG. You get antihistamines as well. But in my practice, I don't do that. And I'm not aware that it actually have the great effect. So the most important thing is the rate of infusion.
What about hydration? Like making sure you're hydrated before you start?
Yeah, I know people are talking about that. You get a lot of fluid already when you get the IVIG infusions. So I'm not sure how important it is, but that's the point of giving a saline. But you could also drink some water or iced tea while you get the infusions. That should be the same effect.
Okay. Yeah, because I've been on a couple platforms and they get really bad headaches and they're terrified because they think something's wrong. And I'm like, no, that's normal. That's normal. Just, so it's good to know exactly what we can expect. Okay, so can you explain the difference between IVIG and SCID or SubQ?
Yeah, I know the drug itself is the same. So you get the same drug, either you get it intravenous or subcutaneously. So the difference is the administration form. So you can have it in an IV line, or you can have it a SubQ infusion in your skin. When you give intravenous infusions, you can give a lot of IgG very fast. And that's the limiting factor when you have a subcutaneous treatment. So you have to split up your doses more. So if you have a regimen having intravenous immunoglobulin every 4 weeks, for instance, or every 3 weeks, like in some of the trials, then you have to split it up. So you get the subcutaneous infusion 1, 2, or 3 times every week. And so that's a practical thing of it. Also, you can have the intravenous treatment. You often have to go to the hospital or have a home care nurse to come and start up the infusions. While the subcutaneous treatment, you can infuse yourself. So you just have a pump and you get the medications at the drugstore, and then you don't need to have a schedule for it. You can take it whenever you think it's appropriate. There have been some comparing studies, and it seems you compare 10 patients with IVIG and 10 patients with SubQ, it has similar effect. I think the most important difference is the side effects. So especially patients who experience severe infusion-related side effects, the headaches, the flu symptoms, they will not have the same amount of side effects when they get SubQ infusions. And many patients don't have any of these symptoms at all. On the other hand, when you get the SubQ infusions, you can have some skin reaction at the site where you have to put the needle in. And obviously, you don't have that with the EV lines. Another thing that I hear a lot from my patient is they kind of dislike these, we call it treatment-related fluctuations. That means every time you get near the time for infusion with IBIG, you feel some deterioration in your symptoms. So you get weaker before you get the next infusions. Of course, you can give the patient IBIG every week or every second week, and then you will probably get rid of it. But it's much easier when you have the SubQ and give it every 1 or 2 times every week, then you don't have the treatment-related fluctuations. So that's some of the differences between IV and subcutaneous immunoglobulins.
Great. I mean, that's exactly why I ended up switching to SCIG, because of the side effects from IBIG, and it's been a life changer for me. So if you want to make the transition from IBIG to SCIG, can you explain the proper way that it should be done so that they can be successful? I hear a lot of stories about people trying SCIG and then it doesn't work because they didn't transition properly. So can you explain the right way to do that?
Yeah, I heard, I know it's a problem someplace. I think the main problem is that people don't have enough experience yet with the subcutaneous treatments. And with time, I think more and more places have more experience with the subcutaneous treatment. So I think it will improve. And I'm not sure there is one particular way that you have to do it, but I can tell you how I do it in my practice. So if I have a patient on maintenance IVIG treatments, for instance, 1 gram every 3 weeks, then I just take the same dose, so you get the same amount of IgG, and you just split it out in weekly infusions. So you get, for every 3 weeks, you get the same amount of IgG. But then the next important step is that you should monitor your patients, because many patients will feel comfortable with that dose. Some patients would even need less IgG when it's subcutaneous given, but some patients also need a larger infusion or a larger dose. So I think that's a good point with all patients with MMN, either on IVIG or subcutaneous, that you monitor your patients and find the most effective low dose of treatment. So if the patient say, "Oh, doctor, now I'm deteriorating after you switched over to SubQ," then if it's a really bad deterioration, I would give an intravenous infusion, because you know it works right away. And then I would adjust the dose, maybe increase it 20%.
Okay, great. So unfortunately, there's a lot of people that more than I was hoping for, that don't respond to IVIG, or maybe SCIG is not an option because they're very deteriorated in their hands and they can't do the needles or have somebody to help them. So if you can't do either one of those, is there any other options for treatment for MMN?
Well, the treatment options for MMN is rather limited. So if you really have a bad MMN, there has been some case reports that chemotherapy like cyclophosphamide could have a beneficial effect on MMN patients, but that would be in a very, very limited number of patients because it has some severe side effects. So actually, if you don't respond to IgG, then first of all, I would put a question mark if you have the right diagnosis. But if you don't tolerate it, then it's actually pretty limited what the next choice should be.
So what percentage of MMN patients have a notable improvement each time they have IBIG or SCIG?
So you mean these treatment-related fluctuations?
Well, no, like, so what percentage of people do respond and have noticeable treatment with IBIG or SCIG? Do you know that?
It's very high. I think it's more than 90% of the patients And again, you have to reconsider the diagnosis if they don't respond to treatment. Or you can have a very chronic MMN and a lot of axonal degeneration. So you can have some fixed symptoms that actually doesn't respond to the treatment.
So are there any, we're all hoping, is there any new treatments on the horizon for MMN? Anything we can look forward to?
Well, I have to say that I looked at clinicaltrials.gov earlier today, and I think the result was just as bad as last year I did it for my presentation for your summit. Actually, there are no active recruiting studies at the moment in MMN. And you know, it will take several years just from initiation of a study till you have a drug on market. So at the moment, I don't think for the near future there will be any new treatments for MMN. But I have been in contact with companies, they are planning, and some of the companies are in late stage of planning clinical trials also in MMN. And the candidates are mainly taken from other neuromuscular disorders like CIDP or myasthenia gravis, Guillain-Barré syndrome. So some of the drugs that seems to have a good effect on these disorders are probably on the way in MMN too.
Okay, well, that's good news. So I was on IBIG for 2 years and switched to SCIG for 7 years ago. I've been doing really well. But a lot of us worry that eventually the IBIG or SCIG will eventually stop working. Is that a possibility?
Mainly, patients with MMN will continue to have a good effect of IVIG or SubQ IgG. It's not like you make antibodies against the treatment or you need more and more drug to have response. So I think, again, you can have the two situations that you have some chronic non-responding symptoms. If you have had nerve injury for a long time, sometimes you wouldn't respond anymore to treatment because you have lost the axons down to the muscles. So these muscles won't respond anymore. But if you have some new lesions, then you will continue to have some kind of response to IgG.
So I've been really fortunate. My symptoms haven't progressed in 9 years, but I know others have. Is it possible to stay stable forever as long as you're on treatment?
Yeah, it is possible. But I also have to say that there is a need for new treatments for this disease because many patients will experience that there's some kind of deteriorate down the road, even if they are on the best or optimal treatment. But it's not dramatical and it will progress very slowly. But I think a large proportion of patients have the problem that they deteriorate a little bit over time.
So I know that MMN doesn't go into remission, but I've heard the word hibernation kind of tossed around, that maybe it just might stop for a while or not progress and you don't have to be on treatment. Is that true?
Yeah, I see patients that can have a treatment pause for years sometimes. But I think it's a certain category of patients that have very little activity or very mild MMN. That's the most of the patients I see that can be out of treatment for long times. But it is a slowly progressive disease. You have the stepwise, so you can have one nerve only affected for years. And in that period, you can probably do fine without having any treatment. So the disease have to, this stepwise kind of nature of the disease means probably that sometimes it is getting active in some of your nerves, and you don't know where and when.
So my doctor asked me if I wanted to go off treatment for a while, and I was terrified because everything's going good. I didn't want to mess with that. So how do you even know, like, if somebody can go off treatment or not and be okay with that?
Yeah, that's true. You wouldn't ever know if you didn't stop treatment sometimes. From treatment trials, I have the experience that if you stop treatment and you relapse and you initiate treatment fast, that means within a few weeks after you start deteriorating again, then the patient will come up to have their habitual performance level again. So a short time relapse probably wouldn't do any important long-lasting damage to the nerves. So I agree, you wouldn't find out if you didn't try, but you have to have some kind of assurance from your doctor that if you go into a relapse, then you should start up treatment right away.
Yeah, I'm too chicken to do that, so I'm not going to. So do you think with COVID and everything happening and plasma donations down, do you think there's going to be a shortage of IBIG and SCIG down the road?
Well, I know there's a shortage already, so it is a big problem. I think for many countries there has been a shortage of IgG already before COVID-19, but in the developed countries where we have money to pay for it, then we have always had the possibility to get the IBIG or immunoglobulins. But in my country, I come from Denmark, and I never experienced shortage. But at the moment, I've been told that we need to reduce our use of immunoglobulins with 30%. And if we don't do that, then at the end of each month, we might don't have the option to treat some patient that really needs it. So it is a huge problem at the moment. And in a disease like MMN, it's difficult because you don't have any treatment options. So if you, for instance, can give plasmapheresis or corticosteroids for some other disorders, then you should probably try that. And in MMN, it's important not to overtreat. That means if enough to have 1 gram every 3 weeks, then you shouldn't give 2 grams every 3 weeks. So you have to adjust it down to try to overcome this shortage. And I'm afraid that the shortage will last even when we get over the COVID-19, because it was already a problem before that.
Oh, that's scary. Okay. So can you explain what fast circulation is and how we can reduce it when, like, the IBIG starts to wear off? And also, does it tend to happen in areas that will eventually atrophy?
Well, a fast circulation is a muscle contractions that comes without you want it to come. So when you have the fast circulation, you can see it. You can see the muscle move under the skin, and sometimes you can also feel it. It is in the spectrum of other involuntary movements. So maybe it's not always fasciculations, because I mean, in MMN, fasciculations are not a really big problem, but tics, where the muscle actually contracts and you can feel it and can be painful and annoying, or muscle cramps is also a problem. And to distinguish that from the fasciculations can be difficult. if you have fasciculations all over your body, then you should think about ALS, because it's a sign of acute denervation. So you see the fasciculations when you have an active disease process going on. So yeah, theoretically, you can say that if you have fasciculations in a muscle that still works fine, then it could be a sign that there is something going on. But it's not that easy, because even healthy people can have fasciculations and it doesn't hurt their muscles at all. I think it's more annoying symptoms from the patient and a diagnostic marker for the neurologist. And it's also a very scary sign for the patient, because when they look up on the internet for Lou Gehrig's disease, then you will always find the word fasciculations. So of course you get afraid when you see someone or feel someone.
Yeah, I know. I'm always, when I get it anywhere else besides in my legs, I'm always getting a little concerned. Okay, so this next session kind of goes into more self-care. So I know a lot of the people have issues with just feeling better, the best we can. So exercising, there's always a lot of debate. Is it possible to exercise too much with MMN? Try to compensate by keeping our muscles that are still good, healthy, but then we're also concerned that we might be doing too much or over fatiguing our body. So what's your thoughts on that?
Yeah, I haven't seen any studies suggesting that too much exercise will damage your nerves or your muscles in MMN or in many other muscle or nerve disorders. So it's not a direct damage to the muscle and nerve. You shouldn't be afraid of that. But of course, if you are deconditioned and you don't do any exercise at all, then you can't just jump up and do very high intensive exercise every day from one day to another, because then you will get injuries to your muscles, to your tendons, to your bones, and then it will just set you back. And then there is the mentally or fatigability thing also. So you shouldn't overdo. So I would say my recommendation for exercise is mild to moderate exercise, and you can gradually increase, or you can just do some maintenance exercise. But my recommendation is to do regular exercise, so you have some muscles that you can compensate with when your disease, if your disease will progress.
Okay, so I guess I need to get back on that elliptical and start exercising more. So one of the things I really struggle with, I know a lot of us do, is fatigue. I mean, it's just, and I try to explain to my husband, it's not the same as being tired. It's like you just feel like you're just not completely charged up ever. And I miss those days of waking up and feeling fully rested. Is there anything like eating supplements or anything we can do to just help with the fatigue part of MMN?
No, I mean, fatigue is a big problem in many neuromuscular disorders, and also you see it in MMN. So I wouldn't prescribe any drug to help you with fatigue. So there are some studies in other diseases that indicate that physical activity and exercise actually can help with fatigue in some patients. So I would always start recommending that. But if that doesn't help, my only answer to that is that you need to adjust your work and social life to have the opportunity to take a break during the day and don't overdo things.
I know it's a vicious cycle because you're really tired and you need to exercise, but you're too tired to exercise. It just never happens. So I've been there. So what about diet? Are there foods like that we should, like I know for myself, I just feel better when I don't eat gluten. And I've cut out dairy and my stomach does feel better. I don't know if it helps with MMN, but what are your thoughts on like anti-inflammatory diets? Just eating healthier in general.
Yeah. I hear that questions from so many patients of mine because I think it's a natural response that if you can do something yourself, you would like to do it. But I have to say that I haven't seen any studies that has convinced me that I can recommend any specific diet. So what I recommend is just to have a normal, healthy diet. And then it's very important to avoid getting overweight, because if you have weak muscles and you are overweight, then you have a bigger handicap. So avoid overweight, regular, normal, healthy diet and exercise. So that's my recommendations. But also people without a chronic disorder feel better when they eat certain kind of diets. So when you tell me that you have a diet that you feel better with, then I wouldn't say to my patient, no, don't do that. That's a nonsense. So if you feel better, then of course you can do it. But I don't have any data or studies that can say that all MMN patients should eat like that and not eat like that.
Okay, that makes sense. So I was very fortunate that I was sent to a doctor that knew what he was doing with MMN, and initially he even misdiagnosed me, and then we figured everything out. There's a lot of people out there that are not as fortunate with their medical care. And what should they look for in a neurologist, and what are some signs they need to move on and go see another doctor?
Well, that's a tough one. but of course, you need to trust the doctor that you are having. That's the case if you have MMN or you have any other disease. So that's very important. So if you don't trust your doctor, you need to find someone else. But of course, it sounds like you have had a really nice doctor and you can make conversations and you can say your own opinion, and in that way I think you can get to some kind of agreement with what kind of examinations you need, and also if it doesn't seem that you get the results that you expected or you get the treatment effect that you expected, then you should probably ask if someone else should look at you. So, and of course, if you have a rare disorders like MMN, I would like to see a neurologist that have seen other patients with MMN. So if you are in a small community hospital with a neurologist who never saw an MMN patient before, then it could be a good idea to get a second opinion from a larger center.
Would that be like a neuromuscular neurologist that you would want to look for?
Yeah. So a doctor that know about ALS, know about CIDP, know about MMN, know about neuropathies.
Okay. And I also want to mention that if you haven't already, for other people watching, that the Centers of Excellence on the GBS-CIDP Foundation website has a list of really good facilities that you can contact in your area all over the world. So there is that as well. So Dr. Harbo, do you have any final thoughts or anything you'd like to add before we close?
I think we have been around MMN and had a really, really good conversation. So I'm really happy that I could talk with you today. So no, I don't think I have anything that I missed today.
Okay, great. Well, we so appreciate your time and taking it out of your schedule. And it was fun and nice to get to meet you face to face, but not in person. So maybe one day. So that is it for Ask the Experts MMN breakout session. On behalf of Dr. Harbo and myself, I would like to thank you for joining us and enjoy the rest of the symposium.